But I think the first thing I wanted to say really was, what is the future? What are we going to do, and why are we thinking about all of this? The future is going to be people making decisions for themselves. The future is going to be those people who are currently at school. Those are the people who are going to be sat in seats like this in 20 years' time. 30 years' time, they're going to be the people in government making the decisions. They're going to be the consultants, and they're going to be the GPs, the nurses, and they're going to be the patients. So let's not forget that. So the question isn't about what can we actually change, it's more when is it going to change. It is going to happen, so we just need to think why we want to do something differently now rather than just sit and wait. It does work. I just wanted quickly to say a few facts, why we're thinking about this and what it is that's important to me. And as you can see from that slide there, the type of people that we're thinking of, and I'm particularly interested in my policy brief at the Department of Health, are those people living with chronic long-term conditions. So it's both physical and mental health conditions. People who are going to be living with this for the rest of their lives. They're not going to mysteriously suddenly find a cure. This is something which for 8,760 hours in a year, 365 days every year, they're going to have to live with this. And they are probably the experts in those fields. They have to find ways of living with pain, have to find ways of living with all sorts of different diseases and conditions. And they are the experts in themselves. So we're very keen on understanding how we can support people to make decisions for themselves. That's self-care agenda. Why? Well, as I say at the bottom there, these people are the largest users of health services in this country. There is about 15, maybe 16 million people in England. It's about a third of the population, but they use about 70% of all the budget, both health and social care. So that's why we're really interested. And they are generally the people who say to me, I don't want to spend time in hospital. I want to live my life the same as anybody else. So why have we got a system which is geared up to admit them into hospital and give them the care, often very good care, but the care in a hospital situation, which isn't really what they want and is often more expensive and can actually prevent some of the self-care agenda that I've just mentioned. You've probably, some of you already seen all of this, so I won't go into it in too much detail. This is the model that we've been promoting for some time now. It's based on the model that was designed in the 90s in, of all places, in a number of places, but particularly in America, the chronic care model. There's lots and lots of academic and evaluated medical evidence that this system works. Essentially, you look at the population, at their risk factors, you look at whether they're going to be going into hospital more often, and then you can start to intervene at the right time. And as you can see, as you graduate down to the bottom, you've got more people who are able to support themselves and have that quality of life that the people at the top would like. So that's how we try to think about it. And the reason I'm talking about that is very simply, if we're going to get into telehealth and telecare, it is not about technology. It isn't about the bits of kit and the wonderful things that we've seen next door and elsewhere. It is about what I just said. It's that service. How do you build it into that service to give people the opportunity to have that quality of life that other people have, so that they don't end up going in and out of hospital. So telehealth, why have I put that up? Well, because I often go to places and I talk to people from all over the world. And I was with some people from Singapore just a week or two ago. Telehealth to them means a different thing. It means telemedicine to me, which is, telemedicine is much more about patient to clinician or clinician to clinician contact using video enhanced approaches, so you can actually see each other at the same time. But telehealth is about remote monitoring. That's why I put this slide up, just so you know exactly what we mean by telehealth when we talk about it. It is about giving people the opportunity to care for themselves at home, monitor their own vital health signs, send that information to a health professional who can make decisions based on that information. But actually the thing which I think sets this apart from telemedicine is it gives the opportunity for the individual to self-care as well, because they are seeing the results and can have a look at the trend as well. So it's about in-home monitoring of vital health signs. And let's not forget Telecare. Telecare, again, a lot of people talk about that in a different format. In Australia, it's very much more about that ability to use telephone to do support mechanisms that way. Telecare is much more about, here I think, it's about independent living. Using the devices at our disposal to provide alarms for people if they, I don't know, have some early onset dementia. Maybe they've left the gas on, or they've left the front door unlocked, or they've left the bed at night and their carer can see where they've gone. It's that type of thing. And we're very interested in both of those, telehealth and telecare. Those of you who have had the dubious pleasure of being in an audience where I might have spoken recently will have heard me say this. But what is the difference between something like telehealth, telecare, and a stethoscope? They both transmit the data from the individual, me, the patient, to the professional, the nurse, doctor, or whoever. So what's the difference? The difference is distance and scale. With a stethoscope, if you think about it, that's technology from a bygone age. People will have started listening to patients' heart rate using their ear against somebody's chest. Then they'll have used a trumpet. And eventually somebody came up with the idea of a stethoscope. And it's been refined and developed over the years. But they both transmit information. So telehealth is very much just about transmitting that information from one to another. The difference is it can be done over a distance, and it can be done at more than one person at a time. So I don't think we need to be really frightened of technology. You know, can we trust it? Well, I think we can. We use technology every day. I'm using this, I'm clicking, it's flashing up on the screen. You're all watching those slides. You have varying degrees of interest in what's on them, but effectively you've seen the technology working. We have mobile phones, we have computers, so we use it all the time and we trust it, we believe in it, we think it's great. So what's the difference when it comes to healthcare? We already use lots of technology in healthcare. The MRI scanner, do you remember the space in the 90s about let's raise money for the local hospital for an MRI scan? If you'd actually trace the history of the MRI scan back, it's somewhere in the 1940s, I think it's about 1947, somebody first came up with the idea. A Frenchman, I can't remember his name now, but he came up with this idea. By about the 1970s, they became laughingly portable, probably about the size of this room, but they became economically viable for people to have, but they're still quite expensive. By the 1980s, they became commercially viable for people to start using and developing. By the 1990s, everybody was wanting one. And now we have mobile MRI scans on the back of lorries that go to and from different hospitals. It's taken a long time for us to get to that point. But the question I have is, if we know those things work, why does it take so long? Why do we go from being very good at innovation to not being very good at making it wide scale and use? And often the answers can be seen from people like Jim Carroll. Don't be put off by the fact that he's a futurist, but he asked those questions in it was an address he gave, I think, back in 2009-10 to I think it was a World Health Organization conference. And he started from the basis of saying, well, what do we look for? What are we looking in terms of down the line of healthcare and in terms of the general population? And as it says on there, you know, we could be seeing in by 2020, you know, the baby boom, doctors, medical professions. He talks about the 239th generation of the iPhone, actually, which I don't think you'd be too far away when you look at how quickly these things come out. But what he's saying is, essentially, let's not be afraid of change. It is coming. It happens all the time. And if we just look forward and stretch our imaginations to, well, what type of care do people want and how are we going to support them using the equipment that we have now, stretch your mind forward a bit by thinking, what did we have 10, 20 years ago, what we're going to have in 10, 20 years? It'll be completely different to what we have now, but it'll be doing similar things. A great analogy was given by a colleague of mine, Dr. Kumar. His GP was in Newham, is now in Southampton. And at the King's Fund, I was sharing a platform with him. And he talked about user interface, and I thought this was a really good example of how we see technology changing, so let's not be afraid of it. And he talked about the motor car in the 1930s. You would sit in a seat, you would hold a steering wheel, you'd have 3 pedals and a lever, and you would make the thing move. 2012, you sit in a seat, you have a steering wheel, you have a little lever and 3 pedals, you make the thing move. But the 2 vehicles are completely different. Technology has taken over. They become a different beast altogether, but they do the same thing, take it from A to B. And that's where I start thinking in terms of, let's not be afraid of the technology. Let's not wait for the next generation of technology. Let's start using it now and build as it starts to grow. That's just reiterating what I just said. People of young generations today, they're going to be the ones in the future. So they're not going to sit here and say, gosh, wouldn't it be nice if we had? They're going to say, why did those people all those years ago angst about it? It's obvious. So the whole system demonstrator program. So forgive me for rambling a bit, but I just wanted to set a scene. Why were we interested in the whole system demonstrator, and what was it? Well, back in 2006, all of these questions that I've just been toying with were bouncing around in the Department of Health. And the single factor that was there was, well, this type of technology exists, but it's not being used, so why not? And it became obvious that one of the major reasons it wasn't being used was because people didn't know if it was making sense. Is there any evidence? Actually, if you look at and have the time to do this, look at all the evidence, there's lots of studies across this country, across Scotland, across Europe and across the world. Lots of studies have been done over a number of years, pointing the way that if you intervene in somebody's life, using the technology, remote monitoring, you can reduce their dependency on hospitals, and you can improve the quality of their life. But they've all been done at a small scale. By small scale, I mean anything from 10 or 20 to 200 or 300. So back in 2006, we committed to doing something on a much grander scale. By 2007, we more or less got the design and the money and the ethics approval in place. By 2008, we launched the study. And we set ourselves a target of getting 3 different sites using different types of kit so that you couldn't have a bias. You weren't using just one particular manufacturer's particular type of equipment. We wanted 3 sites which had a good combination of rural, semi-rural and urban. We wanted a good number of people, so we went for 6,000 in order to get at that scale. And we wanted to have that roughly, and it came out about roughly in the end, half and half in terms of control and intervention. And we looked at telehealth and telecare. And in the telehealth world, we were particularly interested in 3 diseases. And those were coronary heart disease, diabetes, and do you know, see that being on leave? What was the third? COPD, thank you. I knew Charles would remember. So we had those diseases. And again, they were fairly roughly evenly spread across the 3 sites.